Thank you, sir. It's always a pride and pleasure to be your student as well as to be in your IC. Thank you so much for having me here, sir. So I'll be talking on the management of congenital fibrosis of the extraocular muscles. So congenital fibrosis of the extraocular muscle is a hereditary non-progressive disease causing restrictive ophthalmoplegia. It's a subset of the congenital cranial disinnervation or congenital innervation disorders. So ptosis is a variable component often present, characterized by poor bells. Initially, it was thought that the primary pathology was fibrosis of the extraocular muscle. Later on, now we know through detailed MRI studies that it is hypoplasia or aplasia of the third and fourth nerve nucleus, and EOM atrophy is a secondary cause. A total of 7 genes have been identified. So just to summarize this busy table, we have 5 main types of CFEOM. So CFEOM 1 is characterized by large exo and hypotropia, large exo and hypotropia, and the most commonly involved gene is CIF21A. CFEOM 2 is characterized by a large angle exotropia. In CFEOM 1, it was a large hypo and exo. CFEOM 2, it's a large angle exotropia with pupillary involvement. CFEOM 3 is marked by asymmetry, and CFEOM 4 is called Tuchel syndrome, and CFEOM 3 plus oligodactyly, and CFEOM 5 is synergistic divergence. So it may have a number of systemic and ocular associations. Among the ocular associations, infantile nystagmus syndrome, optic nerve hypoplasia, retinal dysfunction predominate. And in systemic associations, you can have Joubert syndrome, you can have Prader-Willi, which has diabetes mellitus, and you can have arthrogryposis. So you have to look for all of these. So the MRI findings is characterized by, this I have taken from an article, and absence of cranial nerve third and sixth have been demonstrated in majority of cases. The EOM atrophy to a certain extent correlates, but the clinical picture does not. So if you have a congenital absence of third and sixth nerve, either on both sides, so that was how it was worked out that the primary pathology is hypoplasia or aplasia of the third and sixth nerve nucleus. So this is the hallmark of CFEOM 1, which is a substitute convergence on attempted elevation. So when the patient tries to look up, you have a substitute convergence. So you may have associated ptosis. The first patient did not have a good amount of ptosis, but here you can see that the patient has ptosis. When the patient tries to look down, the globes tend to diverge out. When the patient tries to look up, you have a substitute convergence. So because the globes would not rise above the midline, these patients often have a chin elevation, and they develop a number of head postures to compensate for the lack of elevation. So CFEOM1 is characterized by autosomal dominant inheritance. So you see at the top the father and the daughter, both of them having a congenital fibrosis of the extraocular muscle. So this is a patient with bilateral ptosis, and this is how she has adjusted to use both her fingers to lift the lids when you ask her to read. I have a short video. I've gotten the consent for this. So when you ask the patient to read the letter chart, first she tries to avoid, but this is how she adapts to read this. So this is what we want to correct. So the management, of course, is as for any other strabismus, the preliminary management. You have to take care of refractive errors. You have to take care of the amblyopia management. And surgery is required when you want to clear the visual axis because of a ptosis or because of severe hypotropia, to alleviate the head posture and to correct the primary position alignment as far as possible, in addition to supportive measures like lubricants, the importance of which cannot be understated. So the challenges are, one is that the FDT is variable. Even though the term is congenital fibrosis, the force reduction is not always positive. So hypotropia is the major thing that you have to correct. So you need a large inferior rectus recession, 6 to 12 millimeter, and anterior segment ischemia is a very important consideration in these patients. Sometimes they may have lesser number of ciliary vessels, and even one muscle surgery may trigger an anterior segment ischemia. They may have fibrotic bands posteriorly, so you need to do a real posterior dissection. For ptosis, you can use either crutch classes or frontalis sling along with a lot of lubrication. So this was a patient with global ophthalmoplegia and congenital restriction of all extraocular movements. So please note, resection is controversial. So wherever you ask him to look, he is unable to look anywhere. The problem was that in the left eye, he had a large esotropia, which was his better seeing eye, with a vision of 6/9. And in the right eye, it was amblyopic because patient had a high myopia. So this was a patient with what is called a Varadi-Pap syndrome. He had oligodactyly, and he also had cryptorchidism, and he also had pituitary insufficiency and growth hormone deficiency. So what we did here was we did a recession of the medial rectus, and I also plicated the lateral rectus. So the hypotropia still is there. But he had 1+ cells on the first postoperative day, even though I had done lateral rectus plication. So I really did not dare to do a third muscle. He also developed another complication, which is a surgically induced necrotizing scleritis. I had also tackled the superior oblique. In addition to the recess resect, I had done a Burke stenotomy of the superior oblique. So he developed this, and not very keen to give him steroids. A systemic workup for any associated rheumatologic disorder turned out negative. So we managed him conservatively with topical reconstituted and N-acetylcysteine eye drops. We also published this, and so eventually the sclera vascularized and he recovered. So this was another interesting patient. So it was a family, both the father, the daughter, and the son. The daughter consented to undergo surgery first. She has a synergistic convergence, and on attempted upgaze, so we did a bilateral inferior rectus recession of 10 millimeter with a nasal shifting, so you don't induce a pattern, along with superior oblique tenotomy. So we got the right eye to elevate a little bit. The left eye did not budge at all. So you'll see that the synergistic convergence has gone away, and the ptosis was managed with crutch glasses. We got her got a satisfactory improvement in head posture, which she was happy with. And so then you have a CCDD with synergistic downshoot, the management of which I learned from Sharma sir. So you deactivate the lateral rectus, and then you transpose the IR to MR. So this was a patient with a synergistic downshoot. So you can see the preoperative video. So as you ask the patient to look out, the right eye just shoots down. So here what you have to do is you have to deactivate the lateral rectus to take care of the exotropia, and an inferior rectus shifting to the medial rectus. The inferior rectus was so tight that I had to use non-absorbable sutures to get it through. So the inferior rectus was disinserted, and with non-absorbable 50 ethibond sutures, and it was transposed adjacent to the medial rectus. So it was so tight, I wasn't very keen to use absorbable sutures. I had used non-absorbable sutures. In spite of that, the patient still continued to have some synergistic downshoot, though it was much better than what it was before. So in spite of that, the patient still continues to have an exo. I would say the downshoot is somewhat better. It really didn't go so much, at least in primary position. If you see, primary position, this was the primary position where the globe is so much hypotropic. But at least in primary position, the globe has come up a little bit. So for all that we did, the downshoot is improved. And this is a patient with CFEOM type 5 with the splits, what we call the splits. So it is a... So here the treatment is to do a lateral rectus deactivation. So we have done a lateral rectus deactivation, and yeah, I'm summarizing this thing. So you still have a synergistic downshoot, but this was a very old patient, and I learnt about this inferior rectus transposition much later on from sir's presentation. So if you are not very encouraged to do the surgeries, I have presented a summary of the outcome. In general, in 35 to 40%, you get a good improvement in head posture. In another 30, you get a fair improvement. This is a patient with a unilateral fibrosis. He wanted to know if something can be done for the enophthalmos. The CT scan had been done outside. So if you note here, the muscles are paper thin. So this is what you get in imaging. All of these patients need orbital imaging to see if any extraocular muscles may be absent or are they present, to get any get an idea of change in course or change in insertions. So thank you so much for.
Thank you, Murali. I think that was an excellent presentation for a very complicated subject, that's the CFEOM. It presents in various ways. Each case is to be handled differently. And we may have to do IR recessions, LR recessions, sometimes superior obliques also have to be managed, and we have it. So that is right. Nowadays for synergistic divergence, I would say the ideal procedure is anti-SLR. Synergistic divergence. So synergistic innervational downshoot, yes. IR shifted to the MR is the right thing. You are doing a targeted strabismus surgery, as I say. It is the inferior rectus is getting innervation during adduction. So put it there. So it's like a child who is always trying to work on some other place, put him there. He's also happy to work there and our job is served. But if it's a synergistic divergence, what is happening is that the lateral rectus is firing during adduction. So in this case, what we want to do is anti-SLR. So ideal procedure for anti-SLR is synergistic divergence. That you always get the lateral rectus to the nasal side, and these children are most happy because they get the adduction, which is at the right time. So I think that is the ideal procedure, I would say. So thank you, Murli. He also touched about an interesting thing, that is the SINS. So the strabismus-induced necrotizing scleritis. Anybody has encountered? Yeah. So unfortunately, yes, even I had a case which was an infantile esotrope. An MR recession I had done on both the eyes, and one eye was okay, the other eye went into a SINS. So it is a terrible thing, a child having that, and what to do. And it was suddenly, I mean, after 1 week, she comes with melting of the sclera and the cornea. So we had to give steroids in such cases. It's an autoimmune response. So you have to give steroids, systemic steroids, and then also did a sclerocorneal graft. Fortunately, we got back 6/6 vision and good convergence. So that is something which is, I mean, it's the, our sins being coming back to